Hi there, and welcome to our presentation today on From Challenges to Changes in Relapsed and Refractory CLL, which focuses on forging an academic and community practice alliance for effective and safe sequential care. I'm Dr. Debbie Stevens, and I am the director of the CLL program at the University of North Carolina, Chapel Hill, and I'm joined today by my friend and colleague, Dr. Lee Jamison, who is the CLL expert at one of our affiliate sites, the Rex Cancer Center in Raleigh, North Carolina. Thanks for joining us today, Lee.
Thank you very much. I'm happy to join you today.
Yeah, and also thanks to PeerView and the CLL Society for providing this session, and to Eli Lilly for providing the educational grant for this workshop. And just a quick reminder to look out for polling slides during this presentation and submit your questions using the live Q&A function, and we're going to answer them throughout the presentation. And finally, throughout the program, we're going to highlight a couple of areas where we have material that's available as a downloadable point-of-care practice aid, and these can be found on the website. You can see the website here, which is peerview.com, and this is where you can download the slides and the practice aids after the event. You can also email us here at live@peerview.com or join the conversation on X at PeerView. Today, we're going to be focusing on the multiple targeted agents that are available in the treatment of CLL. Of course, the first covalent BTK inhibitor that was approved was ibrutinib, and it was approved in 2014. And really, the field and the landscape treatment options for CLL have changed so much in that time period. And we've really highlighted the key agents here, including the next generation BTK inhibitors, acalabrutinib, zanubrutinib, and the most recently approved non-covalent BTK inhibitor, pirtobrutinib. And of course, we also have cellular therapy now approved with liso-cel, which is a CAR T therapy we're going to be highlighting today. This really represents an advancement and the end of frequent use of chemoimmunotherapy for patients with CLL. Also, interestingly, just wanted to point out that as covalent BTK inhibitors were approved, the treatment patterns over time actually show reuse of these agents. So when we think about sequencing, we think, do we use a BTK inhibitor, then a BCL2 inhibitor, vice versa? And it looks like, at least as in the early stages of these agents being available, which has held up until at least 2021 when this paper was published, looks like there's a continuous use of using one covalent BTK inhibitor and switching over to the other covalent BTK inhibitors. Now, in this particular analysis, this was records from Medicare, so it didn't tell us exactly why people were changing, but we're going to go into a few of the reasons why you might want to change from one to the other. Here are some insights from community practice physicians that were taken from a survey of one of these programs that's similar by PeerView, looking at sequential therapy. And we wanted to start with asking the question, can you define double refractory CLL? And, a quarter of the patients said, I'm not sure. About 35% of people said that this encompassed patients who had relapsed CLL after exposure to both covalent BTK inhibitor and venetoclax. And I really refer to that as double exposed instead of double refractory. And then you can see there's about 41% of respondents that correctly identified that this is progression after both covalent BTK inhibitor and venetoclax. And in this part of the same webinar, the community practitioners were asked, if you have a patient with high-risk disease, relapsed or refractory, there's a confirmed progression after venetoclax and a covalent BTK inhibitor, what would you use in this setting? And 45% said they would use a different covalent BTK inhibitor. And we're going to talk about why that likely is not a good option in this setting. But, over half of the people identified that they would use another method of treatment, including non-covalent BTK inhibitors, PI3 kinase inhibitors, or CAR T cell therapy. When we think of these double refractory patients, we really need a lot more treatment options to help these patients. And this is highlighted by a study by the Fred Hutch Cancer Center, which looked at patients with double refractory versus double exposed. And you can see the progression-free survival curves on the left. and see that the median PFS of double refractory was only a short 7 months, and their overall survival was less than 2 years. And so really more effective treatment options are really needed for this patient population, and we're going to be focusing on what to do for these patients today. Also really important is, what do the patients actually think about what is important to them? And this was a survey that was done in September of 2024 by the CLL Society, and asking patients what's important. And the most important topics came up were safety and supportive care. So how do we use these drugs and how do we use them safely? And they were actually very interested in what is the lineup of therapy? What is the order of treatments we should be giving? And how can we maximize length of life and quality of life with these agents? So our goals for today are really to look at patients with relapsed or refractory CLL and help to understand the evidence and guideline updates on these sequential treatments. We want to improve your skills for recommending clinical assessments, prognostic tests, and mutational analyses. We really want to enhance your ability to develop personalized and sequential treatment plans with these newer agents, the non-covalent BTK inhibitors, cellular therapies, and other innovative strategies. And provide with guidance on how to work together with members of the community and your team to ensure safe delivery of care for patients. Just want to take a moment to highlight that the CLL Society provides really excellent resources for both patients and for physicians. And just note that there are patient education toolkits, healthcare provider resource libraries where you can download free patient teaching materials. And I would highly recommend checking out their website, and you can use that QR code to get directly to that spot. Our next section will include some foundations for sequential treatment planning with BTK inhibitors and cellular therapy in relapsed and refractory CLL. The first thing I consider in terms of prognostic indicator is the CLL International Prognostic Index. I really like to have these factors right up front for these patients, because one of the key things that this score can predict is actually a median time to first treatment for patients based on their score. It also really helps with progression-free survival once we start therapy. So when you look at this risk score, you can see that there's 5 main components. These are both genetic, biochemical, and clinical parameters. Over on the grade, you see what score each of these factors gets the patients. And so you can see that the most important adverse prognostic factor is presence of deletion 17p and or TP53 mutation. Either of those, you get a 4 for a score, followed by the next highest score, which is IgHV unmutated status or an elevated beta-2 microglobulin. Each get you a score of 2, followed by clinical factors of stage, any stage greater than 0, or age greater than 65, you'll get 1 point each. You can calculate this score online. There's multiple calculators available, there's one featured right here. And again, I like to do this at diagnosis because I think it can help with predicting time to first treatment and progression-free survival. When you think about these different prognostic factors, how I think about the IgHV just needs to be done once during a patient's course of CLL. It's clearly associated with shorter time to first treatment. I think it's helpful from a prognostic standpoint for patients. It does limit progression-free survival with both chemoimmunotherapy and venetoclax-based regimens, whereas this doesn't really impact your covalent BTK inhibitor-based regimens. Again, just needs to be done at 1 point during the course of their CLL. The other variables that are listed here are really important. Deletion 17p, TP53, these are not the same thing. And there is a difference between if you have a TP53 mutation, some people do not have a deletion 17p, or vice versa. And so it's important to do both of these tests. And I do them prior to any new therapy. So I do them at diagnosis for prognostic purposes and prior to any new therapy. I also check a patient's karyotype because if they're complex, meaning they have 3 or more different mutations, This is considered an adverse prognostic index. And all of these things, deletion 17p, TP53, complex karyotype, they have shorter time to progression, shorter overall survival when patients experience these high-risk things. There are some resources available on the website, so you can access the tools to get a summary of these or to have them available in your clinic. I want to shift to what the NCCN guidelines say about using BTK inhibitor therapies versus BCL2 inhibitor therapies. And you can see that the categories on the NCCN guidelines include both no deletion 17p or TP53 and patients with deletion 17p or TP53. But you can also see that they're actually almost exactly the same recommendations. We're still looking at second generation BTK inhibitors like acalabrutinib or zanubrutinib, or a BCL2 inhibitor, venetoclax with obinutuzumab in the frontline setting. And so, despite making a distinction between the presence of these adverse risks, really the same treatment options are applicable to both groups. When you think about reasons to sequence therapy, there's a couple of reasons why somebody would stop whatever their first line therapy is. These studies actually highlight the first generation BTK inhibitor, ibrutinib, which does have the highest risk of side effects leading to discontinuation. And different studies quote anywhere from 20% all the way up to 40% of patients are going to discontinue for toxicities. Most common toxicities, at least listed in this and by clinical experience, are infection, cardiovascular event, hematologic toxicity, or bleeding. And so these might lead to people discontinuing these BTK inhibitor therapies and needing to sequence on to a next line of therapy. Distinct from intolerance to therapy, which would be discontinuation secondary to side effects, this slide highlights the reason for discontinuation for resistance, most common. Usually when patients have progression on a covalent BTK inhibitor, we're looking at the cause being mutations. And the most common mutation is the BTK C481S mutation. This is the primary reason usually for resistance, and they have been observed with all of the different covalent BTK inhibitors. So these are consistently found in resistance to ibrutinib, acalabrutinib, and zanubrutinib. And earlier we mentioned that some people would choose to sequence from one covalent to another in a case of resistance, and I wouldn't recommend it because of these resistance mutations are very common between all of the agents. Basically what happens is the drug can no longer bind to BTK effectively, and so you kind of slowly lose control of the CLL, which is usually manifest as a slow progression of lymphocyte count and increase in lymphadenopathy. So I just wanted to note here quickly a guidance on BTK resistance testing, because I realize that not everyone has access to BTK resistance testing, and it actually is not currently the standard of care to do these tests. However, I think sometimes they can be helpful because they might have clinical applications in the future. And as these patients sequence through different agents, maybe it will be helpful to know if they have a particular resistance mutations. It can be used to document why they're resistant to therapy. And I think it just adds additional clinical information. But at least right at this time, we don't just randomly do BTK resistance mutations, and if we find one, switch therapy. Because even if patients do have a resistance mutation, sometimes they can maintain on the same therapy for a while before clinical symptoms develop, indicating that you need to switch therapy. And so overall, I think that they're helpful. They're not currently the standard of care to check. There have been much published about BTK resistance mutations, but this is just another study highlighting that over half of the patients found to have resistance to ibrutinib, acalabrutinib, or zanubrutinib have these BTK mutations or a downstream mutation of PLC gamma 2. So it's a really important resistance mechanism for these patients. So as we transition into the next section, I want you to take a moment to answer a follow-up poll on BTK resistance in CLL. The next segment includes further evidence for sequential therapy and including options after covalent BTK inhibitor and or venetoclax therapy. So moving back into the NCCN guidelines and what they have to say about second line or subsequent therapies, and this includes patients both with and without 17p or deletion or TP53 mutations. You're going to see some of the same agents that play into effect here. So acalabrutinib, zanubrutinib, and venetoclax-based regimens. These are all common drugs that we're going to use in sequence. So maybe you use venetoclax first, and then you use acalabrutinib, or maybe you use zanubrutinib first, and then you go to a venetoclax-based regimen. But what you can see popping in down on the lower line is pirtobrutinib, and we're going to be highlighting this non-covalent BTK inhibitor here. This drug can be used in cases of resistance or intolerance to prior covalent BTK inhibitors. And we're going to talk about some of the reasons why, but I just want to highlight that it is a very well-tolerated drug. And so in some cases, patients might tolerate pirtobrutinib where they might not tolerate any of the other covalent BTK inhibitors. And this kind of goes back to our definition of double exposed or double refractory. So we have this whole, circle of patients that are double exposed. So these are patients that just have seen both covalent BTK inhibitor and venetoclax, but they may have discontinued one of those, most likely a covalent BTK inhibitor, for intolerance rather than actually having progressive disease. And so they've just been exposed. However, truly doubly refractory mean that these patients have relapse after both of these. And, of course, this includes progression while receiving this continuous BTK inhibitor therapy. And then for venetoclax-based regimens, we typically define that as progression while on therapy or within a year after the end of therapy when using a fixed duration of venetoclax. So when you look back to the NCCN guidelines and you see, what are the guidelines for patients who have relapsed or refractory disease after prior BTK inhibitor and venetoclax-based regimens, the preferred agents here really have shifted to pirtobrutinib, if you haven't previously given it, and the CAR T therapy liso-cel. There's a couple of other recommended regimens which we're not going to focus on in this presentation today. So again, coming back to the non-covalent BTK inhibitors, these can really address the limitations of covalent BTK inhibitor therapy for CLL. The currently approved drug here, of course, is pirtobrutinib, and we're going to focus on that. But please note that there are other agents in various stages of clinical trials, including nemtabrutinib, which is listed here. So really important, and I think it's important to understand why non-covalent BTK inhibitors can overcome the resistance to covalent BTK inhibitors because of their reversible binding to BTK. And so what I'd like to do is move into viewing a short video to learn more about BTK resistance and binding mechanisms of the covalent versus non-covalent BTK inhibitors.
Let's take a closer look at this specific enzyme, BTK, and its role in B-cell malignancies. In malignant B cells, BTK can become overexpressed. With overexpression, it becomes persistently activated, initiating a signal cascade. This leads to proliferation of the malignant cell, allowing it to thrive, resulting in patients having disease progression. Covalent BTK inhibitors, such as ibrutinib, acalabrutinib, and zanubrutinib, are dependent on binding the BTK site at a specific location in an irreversible fashion, resulting in inhibition of BTK activation. These drugs are incredibly effective for patients with B-cell malignancies, but unfortunately, resistance can occur. The most common resistance pathway identified is a mutation specifically at the C481 site, which makes it difficult for covalent BTK inhibitors to bind. This is the most common mechanism for covalent BTKI resistance in CLL and affects all agents in this class. Decreased binding efficiency results in resistance, which allows for increased BTK enzymatic activity, and ultimately for patients, disease progression. A new class of drugs called non-covalent BTK inhibitors has been shown to be effective even in patients who have disease progression and known resistance mutations after a covalent BTK inhibitor. One such agent is called pirtobrutinib, which is now FDA approved in relapsed refractory mantle cell lymphoma and CLL after at least 2 prior lines of therapy. This drug blocks the ATP binding site of BTK in a reversible, non-covalent fashion, which represents a different mechanism of action, and by doing so is able to overcome the resistance mutations that have occurred in patients who have progressed on a covalent BTK inhibitor.
So coming back to the data about pirtobrutinib, a really key study is the Bruin study, which was our first look at how well pirtobrutinib works for patients with relapsed or refractory CLL. So this study had a median follow-up of a little over 2 years, and it shows patients who had a prior covalent BTK inhibitor still had an overall response rate to pirtobrutinib of almost 82%, which is really impressive. Now you'll see the different responses, including that the complete response rate is low. That is classic for all of the BTK inhibitors, so that is not unexpected. Looking at the median progression-free survival, so these patients are getting almost 2 years out of a non-covalent BTK inhibitor, pirtobrutinib, after receiving a covalent one. A lot of these patients are really heavily pretreated, and you can see if they had not received venetoclax previously, they actually have a little bit longer median progression-free survival than if they were venetoclax exposed, which is about 16 months, what they found of their median progression-free survival. A really important study that was first presented at ASH 2024 was the Bruin CLL study, and this looks at the 321 study really looks at second line and beyond therapy with pirtobrutinib. And what they did is they took a large group, 238 patients that had 1 or more prior therapies. They randomized them to either pirtobrutinib 200 milligram once daily, or they could do investigator's choice. So either idelalisib plus rituximab or bendamustine and rituximab. Patients across both arms received a median of 3 prior therapies before enrolling, although there was quite a big range. So it could be 1 prior therapy versus 13 prior therapies. All of the patients had received prior covalent BTK inhibitor, and half of them had received prior venetoclax, and it was a high-risk patient population. But you can see the pirtobrutinib arm is the red arm here, and the investigator's choice, idelalisib and BR, is the black arm. And you can see a really significant improvement in progression-free survival by using pirtobrutinib in this population. And in fact, they found that pirtobrutinib reduced the risk of progression or death by 46%. So really great improvement. And when you break out and look at all the different subgroups, subgroups that we just talked about were higher risk subgroups, the majority of these groups actually favor pirtobrutinib, and so that's why these are shifted to the left. When you look at time to next treatment, you're also seeing a really prolonged period of time to next treatment with pirtobrutinib compared to investigator's choice. And in fact, pirtobrutinib reduced the risk of starting next treatment or death by 63% and had a median time to next treatment of 24 months. Kind of shifting gears just a little bit and talking about the other recommended treatment in these double refractory patient population. These are CAR T cells. Of course, liso-cel is a CD19 directed CAR T. Basically, what happens on this clinical trial is you would screen the patients, you would leukapheresis their T cells, and they would go to the lab for development. Patients would get lymphodepletion with fludarabine and cytoxin therapy, and then receive liso-cel. And the follow-up of the study has been presented. And these patients, it's important to note that they had no response or they were ineligible for BTK inhibitor therapy. They had high-risk disease, had failed 2 or more prior therapies, and there was a cohort of standard risk disease, failed 3 or more prior therapies. in this is really important to note that your initial response to CAR T really dictated how long your progression-free survival would be after therapy. And those, about 20% of patients were able to achieve a CR, or a CR with incomplete count recovery. And in those patients, there has not even been reached the amount of their progression-free survival. So this is really important and gets people very excited about using CAR T, but you can see that there's also a lot, the majority of patients, 80%, that did not get that CR and so had a shorter progression-free survival. And as you all know, CAR T is a lot more involved therapy involving hospitalization most times, and really close monitoring for side effects. And so works really, really well for a certain population of patients. And so far, we cannot identify going into the treatment who is going to be the most likely to get these complete remissions. So really great for a certain population, probably still needs a little bit of work for other populations. And so when you're making decisions about this is really, a huge decision of where to direct patients. And I think it really takes a team to successfully deliver sequential therapy to patients with CLL. And I think that's really important, and I'm very lucky in our community and leadership of our community site to have Dr. Jamison to work with. And so I'm going to turn over to him and ask, what components do you think are most important with using the team to sequentially plan therapy?
Yeah, so I would just echo the importance of early collaboration with your academic partners, because, community practices do come in varying shapes and sizes, and with that comes different levels of clinical support staffing. So not only does collaboration with the academic medical center get our patients access to experts like you, Dr. Stevens, but also allows them access to the clinical pharmacists, oncology nurse navigators, subspecialty care if needed, such as cardio-oncology, and then subspecialized hematopathologists, all of which can really dramatically improve outcomes.
I know, I couldn't agree more. And I think it's a big decision going for non-covalent BTK inhibitors versus CAR T, and that's kind of one of the things we wanted to focus on in our decision making today. And when I think about non-covalent BTK inhibitors, I think, people really with any performance status can go on these. You want people with a preference for oral therapy. Maybe they can't travel or don't want to go to the hospital for aggressive therapies. Most comorbidities can fit with non-covalent BTK inhibitors. It doesn't matter what your age is. You can usually access these therapies pretty quickly. And so if you need urgent therapy, a non-covalent BTK inhibitor might be the way to go. Thinking about CAR T cells, you want people to have a really good performance status. These people might be younger, but there are some older individuals that might have a good performance status and limited comorbidities, and they still could qualify for CAR T. And just keep in mind that you have to plan for this. So it takes some time to get insurance authorization and to collect T cells, to process their T cells and get everything set up for them to get their lymphodepleting therapy. And so it's not something that can happen tomorrow or even next week. We're talking about a month or two of planning. And so, sometimes you can use these non-covalent BTK inhibitors to actually bridge until CAR T. And so, Lee, I'm going to have you talk about some of the safety considerations involved with pirtobrutinib.
Yeah, certainly. So when considering starting a patient on pirtobrutinib or a non-covalent BTKI inhibitor, the standard dose is 200 milligrams once a day, with some recommended dose reductions for patients that have reduced renal function, starting with a GFR of 30 or below. And then, of course, there's also the possibility for a number of drug-drug interactions. So referencing our team-based approach, we talked about a few slides previously. This is a great opportunity to get clinical pharmacy involved and do a really thorough medication review, as patients that are on strong CYP inhibitors should seek alternative medications if possible, but if it's unavoidable, they can start with a reduced dose of the pirtobrutinib of 50 milligrams a day. No dose adjustments required for a moderate CYP inhibitor, but those patients who are on moderate to strong CYP inducers should also consider alternative agents, but can increase the dose of pirtobrutinib to 300 milligrams per day if the starting dose was 200 milligrams. And then thankfully, no dose adjustments recommended if patients are on a PPI or other acid-reducing agents. These patients, similar to other or the covalent BTK and inhibitors, need to be monitored closely for clinical signs and symptoms of bleeding, cytopenias, infectious complications, cardiac arrhythmias, and of course, ongoing monitoring for the development of a secondary primary malignancy. Looking at some data from the phase 3 Bruin CLL-321 trial, the most common significant adverse effects that we're seeing in these patients were similar to those with covalent BTKI inhibitors. So bleeding, cytopenias, infection, cardiac arrhythmia, and hypertension. Rates of grade 3 or greater adverse events were quite low, and again, similar to those seen with the covalent BTK inhibitors. So to further address some toxicities that we can see with non-covalent BTK inhibitors, for any patient that experiences a grade 3 or greater non-hematologic toxicity or hematologic toxicities such as neutropenic fever with a neutrophil count less than 1 or a neutrophil count less than 0.5 lasting for more than 7 days, platelets less than 50,000 with bleeding, or platelets less than 25,000 at any time, we interrupt therapy until the patient's symptoms or cell counts return to a grade 1 or baseline level. And then we try to restart the original dose again, which would be 200 milligrams once daily. The second time patients experience this degree of significant adverse effect, we again interrupt therapy until they recover to grade 1 or baseline, and we restart at a reduced dose of 100 milligrams daily. At the third occurrence, we again interrupt until recovery to grade 1 or baseline status, and we further dose reduce to 50 milligrams once daily. If patients unfortunately experience these symptoms for a fourth occurrence, we discontinue therapy altogether.
Thanks for walking us through the different toxicities and how to manage them. I do find that these non-covalent BTK inhibitors are quite well tolerated, and most patients are able to tolerate them with the management strategies that you have described. When you look at, there are some unique toxicities of the other therapy, the cellular therapy. So really shifting our focus back to CAR T cell therapy, and these can have some really significant toxicities that need to be monitored very closely for. And of course, you all are aware of cytokine release syndrome, or CRS, and neurologic toxicity. And when you're managing this in the clinical trial that approved the liso-cel, 2/3 of patients needed to receive tocilizumab or corticosteroids or both. So it's really important that these patients are managed at a transplant center or someone who is used to identifying and managing these side effects. Looking out for the typical onset of these can happen anywhere from 1 day to about 2 weeks after infusion. And thankfully, the neurologic toxicity was not usually severe, but when it happens, you want to be able to react and give therapy as soon as possible. And so when you think about principles for safe delivery of CAR T cells, you want to plan for the referral center to specialized area and at least one line of therapy before intended use of the CAR T. These patients are going to be pre-medicated with Tylenol, histamine blockers. Before administering CAR T, we have to confirm availability of at least 2 doses of tocilizumab prior to infusion. Our facility and all the others have to undergo a REM certified training. And so all providers have to be documented, certified for this. And I think all of this just goes towards maintaining a safe environment for patients. The AEs to monitor cytokine release, ICANS, hypersensitivity, and these are most common during the first 30 days, but later on, so after 30 days, and this is usually a time when we're going to be transitioning back to community sites or local oncologists, you're still going to be having issues with cytopenias or infections. And just keep in mind that these practical summaries of non-covalent BTK inhibitors and CAR-T are also available as downloadable practice aids from the peer-reviewed website, which we've highlighted before. So before we move on, I just want you to take a couple of minutes to answer follow-up polling on practical aspects of care with non-covalent BTK inhibitors and CAR-T in CLL. So the last segment that we're going to work through is really case-based guidance on personalized CLL care for community practice. And so we're going to be going through a few different cases. So hopefully the data that we've presented so far are really going to highlight how we clinically manage these patients. And so the first case is a patient with high-risk CLL who presents after progression on BTK inhibitor and venetoclax-based therapy. So this is James, an older patient with relapsed or refractory CLL from a rural location who requires travel assistance to the clinic. He doesn't have any major comorbidities. But when he was initially diagnosed, he had unmutated IGHV. His testing for deletion 17 was not performed, and so it was unknown at the time. And in treatment history, in first line, he got venetoclax and obinutuzumab for a year, and this was followed by a 1-year remission, and so relatively short remission time. Had progression. At that time, testing did show a 17p deletion, and was started on acalabrutinib in second-line setting, and unfortunately at 3 years showed evidence of progression. And so James is now 72 years old, slowly increasing lymph nodes, lymphocytosis. He retains a good performance status, but again, requires travel assistance to clinic. And so really just want to go into some key things to highlight and bring Lee into the conversation. And really one of the things I'd like to talk about is, how can your team plan for effective sequential treatment after progression on a covalent BTK inhibitor? What kinds of things are you thinking of?
So to your point earlier, signs of progression don't necessarily mean you have to abandon the current therapy, but it should prompt you to start thinking ahead to the future. And so this would certainly be a case where I would refer this patient to an academic medical center, at least for the consideration of CAR-T and or game planning in terms of sequential therapy with a non-covalent BTKI inhibitor. Given his short duration of response to OB-Ven, I would not consider retreating with this patient. And so, my plan would be essentially to keep him on his current therapy as long as possible, but also plan for a smooth transition to his next line of therapy if and when needed.
Yeah, and I totally agree. And do you think at this point, is there a role for repeat prognostic testing or testing for resistance mutations, or would you wait until you're ready to pull the trigger on next line of therapy?
I think now is an appropriate time for repeat prognostic testing. As you mentioned, anytime you're considering next line of therapy, it's appropriate to retest for for 17p deletions or TP53 mutations. In a community setting, I probably would not test for a resistance mutation, but use more his clinical progression as evidence that he's in need of a different type of therapy.
Yeah, I agree. And, as we talked about, on some previous slides, sometimes I will do the resistance testing, but it's not really to change my therapy. It's just to document, hey, I don't want to give this guy, for example, zanubrutinib if they have a C481S mutation. And so maybe I'm kind of thinking of that in terms of planning for next line of therapy, or, maybe just to document why they are resistant to therapy. So I think, Lee, you brought up some really great points, and you've really described some great factors that influence your treatment decisions, including, waiting until time of return of clinical symptoms before you actually make a change in therapy. Considering that the patient is likely has a resistance mutation, but maybe not necessarily needing to check it, and considering referral to academic center for consideration or preparation for CAR-T, and potentially there might be some clinical trials that this patient qualifies for as well that might be worth considering before CAR-T. And so I think, one of the key questions that people ask is, would you stay on acalabrutinib or switch to zanubrutinib at this point? And so I think you've already answered that a little bit, but let's just highlight what you would do in this situation.
Yeah, I tend to think of acalabrutinib as one of the better tolerated second generation covalent BTKI inhibitors. And so if he's progressing on that, again, it's most likely due to the development of a resistance mutation. And so I would prefer to switch to a alternative therapy such as a non-covalent or CAR T rather than cycle through additional covalent BTKI inhibitors at this point.
Yeah, I think that's absolutely right. And you'd mentioned, would you retreat with venetoclax? And I think there's very much a gray area right now in terms of, how do we know when somebody is truly refractory to venetoclax? And I think we all agree that if somebody progresses while they are receiving venetoclax, that they are refractory. This guy was kind of in a gray area that he had a year of remission. And so I tend to find that remissions are shorter if you do retreatment. And so, how short is it? It doesn't even make sense to do it because, sometimes people might have just a really short remission with venetoclax if you retreat. But, I agree this guy is kind of like on that borderline. And I think definitely, and I'd love to hear what you think. I think if somebody has had a 2-year remission, I certainly would be interested in considering retreatment. But, this guy's a little bit in a gray zone, and I don't know if you have a time frame you would reconsider.
Yeah, I would agree with your kind of timetables there. Certainly a year or less. I'm hesitant to re-challenge with a venetoclax regimen. Those regimens are a year in length, and so ideally you'd like to be, the remission to be at least, if not longer than the treatments. It's a more intense treatment. It's not as well tolerated. So to put somebody through it twice, you really want to make sure they're going to have a durable result. So I think 2 years is a good kind of benchmark to use as the measurement of whether or not I would consider re-challenging.
Yeah, I agree. And I think, then we kind of transition into this phase. Let's say clinical trials not available and we're thinking pirtobrutinib versus CAR T. And now this is a gentleman, he's 72. He's got good performance status, but he might have some logistical complications. So how does that influence your next steps?
Certainly, the location where he lives is something that we need to consider. Thankfully, a lot of academic medical centers do have temporary lodging available. And so that may not be as big of a hurdle to overcome in some circumstances. But what works against you up front with CAR T can work for you in the long run. It tends to be more intense up front with a lot of visits and a lot of travel requirements, but it's also a one-time therapy. And so in the long term, if he's one of those lucky 20% that achieves a long-term remission, he may actually require less contact moving forward.
Yeah, no, those are great points. And I think a lot of people get intimidated by that upfront thought of, gosh, you got to, most times sites require that patients stay locally for, around 30 days. And some people might get intimidated by that. But really, when you look at it, if they do get a remission, then they could be, living locally and managing anything that comes up for a long time after this. I think the other thing that we mentioned, good supportive team is really important here. And most bone marrow transplant and CAR T cell units have really good social workers, case managers that help patients to work through these kind of logistical complications so that they can really get the best treatment options possible. Is there anything in this gentleman in particular with non-covalent BTK inhibitor you might be worried about dosing, safety, efficacy?
He's 72, but it does say that he doesn't have any major comorbidities, so I would assume that he's got good baseline renal function, doesn't have any cardiovascular comorbidities. So I think he would be a good fit. Of course, like any patient, you'd want to monitor him closely.
Yeah, I agree. I think he would do really well. And just keeping in mind that, the progression-free survival or time to next treatment, it's around 2 years, but, also just a good time to start planning for CAR T or clinical trials or whatever might come next, even as you're starting them on a non-covalent BTK inhibitor. And so I think for this particular case, I'd just like to take a moment to summarize some of the key pieces from my standpoint in an academic setting. We think about what are the approved options for these patients in relapsed or refractory CLL, and they include pirtobrutinib or liso-cel. Of course, we're always thinking about non-approved options like clinical trials as well. And just given the history, high-risk features, retreatment with a covalent BTK inhibitor like zanubrutinib, unlikely to be beneficial, questionable if venetoclax retreatment would be helpful. And again, I always repeat testing for deletion 17p, TP53 mutation for karyotype before I move on to a next therapy. I personally would check for BTK resistance mutations, but admit that might not really influence my overall treatment decisions. And so I don't think it's mandatory to do that. And so, Lee, from a community practice standpoint, any other points you wanted to highlight?
No, just to say, obviously early coordination with academic colleagues is certainly important, not only for the subject matter expertise, but also, like you said, access to clinical trials and early treatment planning. And then, we do often think about, what can we do for this patient should, the current therapy, or should he develop signs of active disease while on current therapy. And so, using drugs like pirtobrutinib as a potential bridge to CAR T, there's certainly no reason why somebody couldn't undergo apheresis and the pre-CAR T workup while they were on that therapy.
Yeah, totally agree. So let's use just a little bit of a variation of that case. So we're still with James, who's this older patient with CLL from a rural location, but now kind of switch it to maybe he hasn't been able to tolerate acalabrutinib. So still same initial case. He's an unmutated IGHV, no 17p performed at the beginning. He got a year of VenG, had a year of remission, had progression with deletion 17p detected. Then he's been on acalabrutinib at the recommended dose, so 100 milligrams twice daily is standard dose for acalabrutinib. And he responds well to acalabrutinib, which is always frustrating when people develop intolerance to something they're really responding well to. But after 3 years, had to discontinue therapy because he had persistent arthralgia, musculoskeletal pain, AFib that was unable to be medically managed. And so kind of a little bit different situation, but he's still 72 years of age. He still has a good performance status, but he is having some side effects. And so, Lee, how does this affect the sequential choice of BTK? And, is there a role here for alternative covalent BTK inhibitor like zanubrutinib?
Yeah, I think I mentioned this a bit earlier, but I do think of acalabrutinib as being the most well-tolerated of the covalent BTK inhibitors. And so if he's unable to tolerate acalabrutinib, the chances of him tolerating zanubrutinib or certainly ibrutinib are less. But he's not discontinuing due to progression. So I think having a discussion with the patient about the option of trying another covalent BTK inhibitor is certainly reasonable. But along those same lines, I would be planning early for a transition to an alternative therapy such as non-covalent BTKI or CAR T in his case, just because I know the likelihood of him being able to tolerate another covalent drug would be quite low.
Yeah. And I mean, I agree. I mean, there are, a few data that show, patients who were on acalabrutinib or ibrutinib could transition to zanubrutinib, but, there's also a chance of recurrence of those same side effects. And so, of course, also that all of the side effects like the arthralgias and GI side effects, things like that are going to be highest when you first start something. So sometimes you transition to zanubrutinib and people think, oh, gosh, I can't tolerate this because they get all of those initial side effects. But sometimes if you keep them on for a month or two, if you can convince them to stay on for a month or two, maybe they could tolerate zanubrutinib. But, I agree. I would think about and maybe even try zanubrutinib, but then, plan for alternate therapies. And let's say, would you say there's a role for non-covalent BTK inhibitor right now? Would you potentially recommend pirtobrutinib at this point for the patient, even though they're not double refractory, they're double exposed technically?
I think that's certainly something I would consider as well. We talked about the data from the Bruin 321 trial that does show patients that were intolerant of the covalent BTKI inhibitors were able to tolerate the pirtobrutinib. So again, after a discussion with the patient about either retrying something like zanubrutinib, I think there's certainly a role for a non-covalent BTKI in this setting.
Yeah, and we presented a little data on that Bruin 321 study, and it looked at people even who were prior to venetoclax-based therapy did pretty well on pirtobrutinib. And so, based on that phase 3 study, we may see a approval of pirtobrutinib even earlier in CLL. So I think it's always worth considering, especially because the side effect profile is really, really great. And so, this guy, let's say this guy was on 100 milligrams twice daily acalabrutinib and came in with these side effects to you, the arthralgias, the AFib. What can you do to mitigate these toxicities and, try to keep them on acalabrutinib longer?
Yeah, so certainly, just pain control. Of course, you'd want to avoid any drugs that further inhibited platelet function. It would increase the patient's risk of bleeding, but things like Tylenol or other analgesics, certainly in terms of managing cardiovascular morbidities, cardiology or cardio-oncology referral is always quite helpful in managing these patients as well.
Yeah, I agree. And, acalabrutinib is a little bit strange in terms of its dose reduction because you have to go down to 100 pills or like 100 milligrams once a day, which, is their, per label dose reduction, but, hard to know whether they're getting full inhibition of BTK if you reduce the dose. But I do have some patients that actually do pretty well on just 100 milligrams daily if you really don't have any other options. But, as we just talked about, we have tons of other options. And so maybe, you'd be a little bit more likely to change over to a different therapy. And so, from my perspective, I think a summary of this case, I agree with Lee that if somebody has AFib, I want to get a cardiologist or a cardio-oncologist. We're lucky enough to have cardio-oncologists at our academic center and get them involved to try to manage this. So great. Really, to summarize some of the key findings from this case, from an academic setting perspective, a couple of things that I consider. I have access to a cardio-oncologist, and so I can consult them if a patient experiences AFib, and I think that's really helpful to help manage these. But, most cardiologists are very well versed in handling AFib, so it doesn't necessarily have to be a cardio-oncologist. Also, arthralgia, I agree with Lee that using dose modifications, Tylenol, steroids, even for severe manifestations, can sometimes help. And then when you're considering patients are responding to a drug like acalabrutinib, but discontinuing to intolerance, you can either switch to a different, try for zanubrutinib or go ahead and sequence to pirtobrutinib at this point. And again, this Bruin 321 study really provides some earlier evidence of data for pirtobrutinib than what is currently approved. But I don't know if you have any other points you want to highlight in this piece, Lee.
No, I think that summary just about says it all, except that, of course, we want to work together with our academic partners to make sure that we're sequencing appropriately and have exhausted all of our current treatment options before moving on to the next line of therapy.
Yeah. So let's take a little bit different twist to this case presentation and look at maybe somebody who doesn't have as good of performance status as our prior patient. So this is Anna. She's an older patient with relapsed or refractory CLL. She's got diabetes that is uncontrolled. She's got a history of cardiovascular complications. Her initial diagnosis, she had unmutated IgHV with complex karyotype, but no deletion 17p, and was initially started on ibrutinib, but then had persistent atrial fibrillation and got transitioned to acalabrutinib, had a 4-year remission with that, and then had clinical progression with testing confirming presence of BTK C481S mutation. She got transitioned over to venetoclax and rituximab and actually had progression after only about 10 months after the end of therapy. And so now Anna, she is 80 years old, and she has a declining functional status, so performance status of 2. So, Lee, when you think about someone like Anna, do you think this is a clear case of treatment refractory disease? Does the length of prior remission to covalent BTK inhibitor argue for retreatment, or what would you think about this patient?
I would consider this patient to be, clearly treatment refractory. She had a lengthy remission, but has subsequently developed a known, C481 mutation. So retreatment's not going to be an option for her. And with her progressing within only 10 months of her venetoclax treatment regimen, to me, that defines treatment refractory disease.
Yeah, no, I totally agree. And what do you think, on an extreme end, what do you think about CAR T for this patient? And what do you think about pirtobrutinib for this patient?
So I think at 80 years old with her comorbidities, I'd be reluctant to move forward with CAR T in her case, just given her potential inability to handle the intensity of that treatment up front. And so I would consider her best option moving forward the non-covalent BTKI.
Yeah, I agree. And keep in mind, there may be some clinical trials, even with her comorbidities, that might be, less intensive than CAR T that she might still qualify for. But I agree that pirtobrutinib would be a great option. Do you have experience with older people 80 years of age and older, with pirtobrutinib, and how do you feel like they tolerate the drug?
My personal experience with older patients in pirtobrutinib is a little bit limited, but certainly I know the data backs up the safety and efficacy in this population. And so I would not hesitate to put a patient in her case on that medication.
No, I totally agree. And I do think some people that have been through many lines of therapy sometimes go on pirtobrutinib and think, well, gosh, I don't even feel like I'm on any treatment now, which is a really nice for their quality of life. So I think always good to consider. How about particularly with older patients, anything you would advise your team to follow up on for this patient specifically?
I just think getting the support services involved a little bit earlier and more frequently is important with your older patients, just because they tend to have more needs outside of the clinic space. So careful collaboration with your oncology navigator and other managing partners is super important. The older patients get, and the more comorbidities that they have.
Yeah, I agree. And especially involving, social workers, because there's often considerations of maybe these patients don't like to drive to their appointments, trying to manage them as close to their home as possible with lab work, I think is always a good thought. Okay, let's wrap up this case. And I think from an academic perspective, the things that I would want to highlight out of this case, I agree with Lee. This patient is clearly double refractory. I would not retreat with covalent BTK, especially given the BTK C481S mutation. Given her age, performance status, her treatment history, I think pirtobrutinib is a great option. Lysocell less so, but again, I would highlight that there may be some clinical trials still that this patient might qualify for. Anything else you would think for this case, Lee?
I would just say that when you have older patients that are, physically fit, or even those with comorbidities, a comprehensive geriatric assessment can also be helpful if you're considering, referral for more intense therapy like CAR T.
Yeah, I agree. Okay, well, thanks for that great discussion of those cases. I think these kind of things come up all the time. And so before we conclude, I just want the audience to take a moment to answer polling on choices with sequential therapy in double exposed and double refractory CLL. I just wanted to highlight a couple of algorithms. For example, if you start a patient on covalent BTK inhibitor, you can sequence next to a venetoclax-based regimen. You might consider a non-covalent BTK if they have some comorbidities or patient preference in this area. And then third line, move on to non-covalent BTK or CAR T if they are able to tolerate aggressive therapy. If you start a patient on venetoclax and obinutuzumab as their frontline therapy, I will often sequence the next therapy to a covalent BTK inhibitor. You can consider retreatment with venetoclax and obinutuzumab or rituximab if a patient has had a reasonable remission. And then in third line, we're moving back to non-covalent BTK inhibitors or CAR Ts. And I think sequencing in the setting of BTK intolerance, it's different depending on which BTK inhibitor they're intolerant to. So ibrutinib probably has the most side effects, and so could still sequence to another covalent BTK inhibitor like acalabrutinib or zanubrutinib. I probably wouldn't jump straight to pirtobrutinib, but it could potentially be an option. You could also consider just switching it to venetoclax. If a patient is intolerant to acalabrutinib or zanubrutinib, you might consider sequencing to an alternative covalent BTK inhibitor like acalabrutinib or zanubrutinib, whichever one they didn't get first. But it's possible that those side effects could come back, and so you want to keep pirtobrutinib or changing therapy to venetoclax in mind. And so I think from my standpoint, I just want to take a couple of minutes to sum up some thoughts we had on sequential therapy and involving the academic and community partnership. And I think for selection of subsequent lines of therapy, most important considerations are: what was the prior therapy? Why did they discontinue? If they had a time-limited therapy, what was the duration of response after therapy? What is their performance status and comorbidities? And keep in mind the FDA approved options after covalent BTK inhibitor and venetoclax now approve pirtobrutinib and Lysocell, the CAR T cell therapy. And for CAR T, you want to consider early planning so that you can get those people in line for therapy, and always consider referral for a clinical trial as part of sequential care. And so I just wanted to take a moment to thank Dr. Jamison for his participation in this discussion today. I think it was a great discussion, so thank you for joining us.
And thank you very much as well for letting me be a part of this discussion. And thank you, as always, for your clinical expertise.
You're welcome. And please keep in mind that the audience can visit us at peerview.com at the address shown here. And don't forget to complete and submit your post-test and evaluation for credit. And you can download those slides and practice aids, as we mentioned, throughout the presentation. And you can watch the replay of this event in the next 24 hours and the online activity in the coming weeks. So thanks again so much for joining us today.